Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular section, I'll be discussing some of the important questions in the cardiology. So they're completely clinical based questions and we'll just try to rule out each and every option in the question. So the first question is, so we have a patient who is like 60-year-old and he has the history of 25 years of smoking, presents to the clinic due to recurrent chest pain whenever he walks fast. It is squeezing sensation in the center of his chest and radiates to his left arm. His blood pressure is 160 by 100 millimeters of mercury and the heart rate is 110 beats per minute. The ECG is showing downsloping of the ST segment depression in lead 2, 3 and AVF. What is the diagnostic test of choice? The coronary angiography, stress cardiography, then treadmill test, the myocardial perfusion imaging. So what is this clinical scenario suggestive of? So the ECG is showing that there is downsloping of the ST segment depression, right? And the pain is increasing on walking. So this particular point is suggestive of the chronic stable angina, right? So this patient is having the chronic stable angina. Now this chronic stable angina, it is a form of reversible ischemia, right? It is a form of the reversible ischemia, right? And this chronic stable angina, which is a reversible ischemia, it occurs mainly when there is inadequate blood flow to the heart muscle, right? Whenever there is inadequate blood flow to the heart muscle during the periods of the increased demand. So what is the periods of increased demand? That is during increased physical activity, there is inadequate blood flow to the cardiac muscle, and that is what is nothing but reversible ischemia or chronic stable angina, right? And this particular chronic stable angina, it is a scenario where the cardiac muscle is not getting adequate amount of the blood supply. So how is that you will be able to evaluate this is by the ECG first, and if the ECG is not giving you the exact picture, then the next best investigation will be the treadmill test, right? The next best investigation would be the treadmill test. What this treadmill test will do is, this treadmill test is designed to provoke, or treadmill test is designed to induce the myocardial oxygen demand, or it will increase the myocardial oxygen demand. And at that time, if the ECG is being taken, you will notice that in the treadmill test there will be a downsloping ST segment depression, right? And this downsloping ST segment depression during the treadmill test is the one which will support the diagnosis of the chronic stable angina and as well as the reversible ischemia. Now, if there is any contraindication for the treadmill test, then what are the alternative tests that can be done is adenosine perfusion test, right? Adenosine perfusion test, or if there is any other contraindication for the treadmill test, the myocardial perfusion imaging can also be safely performed. Okay. And what is that particular score which will evaluate and determine the treatment modality in chronic stable angina is the Duke score. So it is the Duke score which will determine the severity and as well as it will evaluate the treatment. And the next important is you take the stress echocardiography. Stress echocardiography and as well as the myocardial perfusion imaging. Even these two also will assess the myocardial activity. But if the individual is not able to do a treadmill test, that is the point when we do this dobutamine stress echocardiography, right? But the point is, in the clinical question which has been given to you, there is no point telling you that the individual is not able to do a treadmill test, okay? And we have few more investigations, that is the PET scan. What is the purpose of the PET scan? The PET scan is used to differentiate between the scar and hibernating myocardium, right? It is the one which will differentiate between the scar and as well as the hibernating myocardium. Okay, that is the purpose of the PET scan. Whereas you take this coronary angiography, yes, coronary angiography, it is actually a gold standard test for the chronic stable angina. But when is that we do the coronary angiography? And this coronary angiography will also assess the extent and as well as the severity of the blockades within the coronary artery. But this coronary angiography is reserved for cases where the patient's symptoms and non-invasive results is warranting further investigation. By the non-invasive results, if you are not able to make out that there is the chronic stable angina, then you should do the coronary angiography. But by the non-invasive test like the treadmill test, if you are able to evaluate that there is an underlying ischemia, then the coronary angiography is not required. So this, once you do a coronary angiography, it is very much definitive that there is a blockade and the patient may be requiring the angioplasty. And stress echocardiography, as I have said you, this is being done with the help of the dobutamine. And when the individual is not able to do a treadmill test, who cannot exercise on treadmill, then we do the stress echocardiography, right? And this myocardial perfusion imaging is being done by using radioactive tracers. The radioactive tracers are injected into the bloodstream to assess the blood flow to the heart muscle. And this myocardial perfusion imaging, this is a non-invasive imaging test that can identify the areas of the reduced blood flow, and that indicates the myocardial ischemia, right? So here the preferable investigation is the treadmill test, okay, which is nothing but we call it as the exercise stress test. We call it as the exercise stress test. All right. So that is about the TMT. The next question is, a 65-year-old man presents to a clinic due to chest pain for the past 6 months. The pain occurs with the physical and the emotional stress, which will last about 7 minutes, and it is relieved with taking rest. He has a medical history of the hypertension, which is currently managed with the medication, and ECG taken during the pain shows depression of the particular segment. What is the significance of this segment on the normal ECG? The segment indicates the atrial depolarization. Segment represents ventricular depolarization. Segment represents the period between ventricular depolarization and ventricular repolarization. And segment corresponds to the ventricular repolarization, right? Now, so let me tell you an important point here, that what is the clinical scenario suggestive of? The clinical scenario which has been given to you, it is suggestive of the chronic stable angina. Okay, because in chronic stable angina, the pain increases, right? The pain occurs with physical and emotional stress, right? And the pain will get relieved on taking rest. That is what is being given in the clinical picture of the individual, which is suggestive of the chronic stable angina. Now, the ECG is showing that there is depression of a particular segment. There is a depression of a particular segment. So, in chronic stable angina, what is that segment which will be depressed? That is, the ST segment will be depressed. Okay, so the ST segment will be depressed. So, this ST segment which is being depressed, what it will tell you? It will tell you the segment or the period between the ventricular depolarization and as well as the ventricular repolarization. So that is what you mean by the ST segment. That is what you mean by the ST segment. Okay. And the next important point you need to know is, in patients with the chronic stable angina, the pain will last for less than 10 to 15 minutes, and you need to be aware of the treatment. What is the first line drug? In patients with the chronic stable angina, you need to give beta blockers. And next to this beta blockers, right? Next to this beta blockers, the other molecules which are very important in the treatment of the chronic stable angina is, you need to give the nitrates, and that is mainly to reduce the chest pain. And you need to give a single antiplatelet, that is either aspirin or clopidogrel. In case of the chronic stable angina, you don't require a dual antiplatelet therapy. Dual antiplatelet therapy is required in case of the unstable angina, but whereas in case of the chronic stable angina, like the single antiplatelet will be enough. Or in all the cases of acute coronary syndrome, right, that is unstable angina, non-ST elevation MI, as well as the ST elevation MI, in these scenarios, you require a dual antiplatelet therapy. Right? In these scenarios, you require the dual antiplatelet therapy. All right. And the very important point you need to understand here is that about the statins. So statins have to be given in these patients. And this statins, they will correct the dyslipidemia, and it also has the anti-inflammatory property, and it has what is called the pleiotropic effect. Okay, so in case of the chronic stable angina, definitely you need to give the statins as well, right? And in case of this chronic stable angina, in case of acute form of chest pain, you need to give nitrates, whereas in chronic angina, the drug that you need to give is ranolazine, right? The drug that you need to give is ranolazine. So that is what you give in case of the chronic forms of the angina. Now, if you take the options here, the segment indicates the atrial depolarization. See, atrial depolarization, it is your P wave in the ECG is your atrial depolarization. And the segment represents ventricular depolarization. Ventricular depolarization is represented by the QRS complex, right? And the segment corresponds to ventricular repolarization. Ventricular repolarization, it corresponds to the T wave, right? Ventricular repolarization, it corresponds to the T wave. Okay, so this is about the waves in the ECG, and I'll show you the table, the P wave. So at this juncture, I'll also tell you about the normal values or normal dimensions of these waves. So you take the P wave normal dimension is, it is less than 1.5 mm in amplitude in the chest leads, right? And it is less than 2.5 mm in the limb leads, right? And what should be the duration of this, the P wave? The duration of the P wave, it should be less than 120 milliseconds. That is about the P wave. Then you take the PR interval. PR interval, it represents the time between the start of atrial depolarization and to the start of the ventricular depolarization, right? From the start of atrial depolarization to the start of ventricular depolarization. That is from the starting of the P wave to the starting of the QRS complex is your PR interval. And the normal PR interval is around 120 to 200 milliseconds, right? So it is around 120 to 200 milliseconds. Okay, and the PR interval is prolonged in case of the AV blocks, and PR interval is shortened in case of the pre-excitation syndromes. Okay, then coming to this particular Q wave. So Q wave, it represents the septal depolarization, right? The Q waves, it represents the septal depolarization, right? Now, what should be the dimensions of this particular Q wave? The dimensions of the Q wave is that it should be less than 40 milliseconds width, and it should be less than 1 mm deep. Okay, that should be the normal Q wave. Now, when will you consider the pathological Q wave? Exactly more than this. So if the duration of the Q wave, if it is more than 40 milliseconds, and if the depth of the Q wave, if it is more than or equal to 2 mm, that is suggestive of the pathological Q wave. Or if the depth of the Q wave, if it is 25%, right? If it is 25% to that of the amplitude of the QRS complex, then also we consider it as the pathological Q wave, right? Then you take this R wave, it represents the ventricular wall depolarization, which is a positive wave. And S wave, it represents the depolarization of the base of the ventricle, which is a negative wave. And ST segment is the one which will represent it's an isoelectric baseline. And it is the one which will represent between the ventricular depolarization and ventricular repolarization. Then coming to the T wave. So T wave, it represents the repolarization of both right and as well as the left ventricle. And what does this QT interval represents? The QT interval represents, it includes both. It includes the QRS complex, the ST segment, and as well as T wave. So it represents the ventricular depolarization and as well as the ventricular repolarization. So that is what is your the QT interval. That is what is your QT interval. Okay. So this is and see, you need to be very much aware of the significance of the QT interval. When there is a QT prolongation, this prolonged QT interval will result in the consequence called as the polymorphic ventricular tachycardia, and that is what is nothing but the Torsades de Pointes. right? That is nothing but the torsades de pointes, which is a very important arrhythmia that can cause a sudden cardiac death within the individual. So that is the reason why in case of the torsades de pointes, what is the drug of choice? The drug of choice will be magnesium sulfate, right? The drug of choice will be magnesium sulfate. So that is what you need to give in case of the torsades de pointes. Okay, so that is about the clinical question related to the ST segment, right? Moving on to the next question. Okay, so we have a 63-year-old male presenting to the cardiology clinic complaining of fatigue, shortness of breath, and occasional palpitations. He has a medical history of hypertension and hyperlipidemia for which he takes medication regularly. He appears pale and his blood pressure is 140 by 90 millimeters of mercury. The auscultation reveals that there is a pansystolic murmur which is best heard at the apex and radiating to the axilla. What do you think is the most likely diagnosis in this patient? The aortic stenosis, mitral regurgitation, ventricular septal defect, and as well as the tricuspid regurgitation. Okay, so valvular heart diseases as such, it's a very important topic, right? So I'll just discuss the valvular heart disease now in detail, all the important valvular heart diseases, right? First, let me try to make out the answer here in this question. So the patient is having a pansystolic murmur, which is best heard at the apex, and it is radiating to the axilla. So these points, they are suggestive that the patient is having the mitral regurgitation, right? These points are suggestive of that the patient is having the mitral regurgitation, right? Now, so you take the other options. In aortic stenosis, the murmur that you will have is the ejection systolic murmur, right? Ejection systolic murmur. And ejection systolic murmur, this is also called as a mid-systolic murmur, right? This is also called as the mid-systolic murmur. Now, this ejection systolic murmur or mid-systolic murmur, it is heard in the aortic area, right? It is heard in the aortic area, and this murmur from the aortic area, it will be radiating to the carotids, right? It will be radiating to the carotids. And the murmur of the aortic stenosis, it will get aggravated or it gets precipitated on making the individual to sit and lean forward and then auscultate. Okay, the individual is made to sit, lean forward and then auscultate. The murmur of the aortic stenosis increases, right? Now, whereas you take ventricular septal defect, you will have pansystolic murmur, but radiating to the axilla will not be there. Okay, so there is no radiation to the axilla, right? Then coming to the tricuspid regurgitation. So tricuspid regurgitation also, you will have a pansystolic murmur, right? So the pansystolic murmur in case of tricuspid regurgitation will not be radiating to the axilla. And where is it heard? It is best heard in the fourth left intercostal space, right? It is best heard in the fourth left intercostal space, and it will not radiate, and that too in the parasternal line, right? Whereas ventricular septal defect, it is heard in the fifth left intercostal space, that is also almost the parasternal line, right? So the points here is, in case of ventricular septal defect or in case of the tricuspid regurgitation where you are hearing the pansystolic murmur, that will not be radiating to the axilla, right? That will not be radiating to the axilla. That's a very important point. Okay, so the answer in this question is the mitral regurgitation, where you will have a pansystolic murmur that is heard at the apex and that will be radiating to the axilla, right? Now, in case of the tricuspid regurgitation, the pansystolic murmur, that whatever you are hearing, that will increase on the inspiration, right? That will increase on inspiration. Okay, now almost all the right-sided murmurs, right? So almost all the right-sided murmurs, they increase on inspiration. And all these right-sided murmurs which are increasing on inspiration, what is this phenomena called as? This is called as de Carvalho phenomena, right? Or this we call it as the de Carvalho sign. This is what is called as de Carvalho sign. So this is about the right-sided murmurs on the auscultation increasing on inspiration, whereas all the left-sided murmurs they increase on the expiration. They increase on the expiration. Okay, and next you need to know that this pansystolic murmur of the mitral regurgitation, it's a high-pitched murmur, right? In case of MR, the pansystolic murmur, it's a high-pitched murmur, and it's a plateau-shaped murmur, right? So plateau-shaped in the sense the murmur will have same intensity throughout the systole, that is between S1 and S2. Throughout the systole, you will have the same intensity of the murmur, and that we call it as the plateau-shaped murmur, right? And in case of the MR murmur, as I have said you, it will increase on the expiration. And this particular MR murmur is best heard in the individual in lying down position, and that too in the left lateral position. Right, that too in the left lateral position. So this will be the description related to the MR murmur, right? Then following to that, you see the next important question on the same valvular heart diseases. So okay, before going on to this question, let me just quickly discuss about all the valvular heart diseases. Okay, so this is the table or the summary of all the important valvular heart diseases: MR, MS, AR, and as well as AS. But before that, how much is the normal mitral valve area? Normal mitral valve area is around 4 to 6 centimeters square. And how much is the normal aortic valve area? The normal aortic valve area is around 3 to 4 centimeters square. It is not 3.4, it is 3 to 4 centimeters square is the normal aortic valve area. Now, coming to the mitral stenosis first. So mitral stenosis is that where the valve area is reduced to less than 2 centimeters square. And this mitral stenosis, we classify that into progressive, severe, and very severe mitral stenosis. So progressive mitral stenosis is that where the valve area will be 1.5 to 2. Right? So in progressive, the valve area will be 1.5 to 2. And in case of the severe, the valve area is around 1 to 1.5. Whereas in very severe, the valve area is less than 1 centimeter square. Right? The valve area is less than 1 centimeter square in case of the very severe. Now, what is the most common cause for the development of mitral stenosis? That will be rheumatic heart disease. Then what are the other conditions which will be causing mitral stenosis? Systemic lupus erythematosus and rheumatoid arthritis. See, both of these are the connective tissue disorders, and apart from that, we have some storage disorders where you have the development of mitral stenosis, and that particular storage disorder is the Hurler syndrome. And apart from that, in mitral valve calcification and congenital disorders like cor triatrium. So these are the etiologies where you have the presence of mitral stenosis. Whereas you take MR. In MR, you have two forms. One is acute MR and the other one is chronic MR. See, your rheumatic heart disease is the one which will cause chronic MR. Whereas infective endocarditis is the one which will be causing the acute mitral insufficiency. So mitral insufficiency is nothing but mitral regurgitation. So infective endocarditis, it can cause the perforation of the mitral valve. It can cause the rupture of the chordae tendineae. It can cause the rupture of the papillary muscles, and that makes the individual to develop the acute mitral regurgitation. And next is the other etiologies for the MR include mitral valve prolapse syndrome and as well as all the forms of cardiomyopathies, dilated cardiomyopathy, restrictive cardiomyopathy, and as well as the hypertrophic cardiomyopathy as well, right? Whereas this chordae tendineae rupture or papillary muscle rupture will result in the acute MR. See, what is the difference clinically between acute MR and chronic MR is, in acute MR, the patient will directly present with sudden onset dyspnea. Whereas in chronic MR, the patient initially will present with the dyspnea and palpitations will occur later in case of the chronic MR, right? Now coming to the aortic stenosis. So aortic stenosis, the valve area is around, normal valve area is around 3 to 4 centimeters square. When do you call aortic stenosis? If the aortic valve area, if it is less than 2 centimeters square, then we call it as the aortic stenosis. Now, in cases of the aortic stenosis, right, in cases of the aortic stenosis, what should be the gradient between the left ventricle and the aorta? So, the gradient between the left ventricle and aorta in a normal individual is less than 5 millimeters of mercury. But if the gradient between the left ventricle and aorta, if it is increased to more than 10 millimeters of mercury, that is suggestive of the aortic stenosis. So in aortic stenosis, definitely the gradient between the left ventricle and aorta should be more than 10 millimeters of mercury. What are the etiologies? So the etiologies, the most common cause of the aortic stenosis in elderly individual will be calcific aortic stenosis, whereas in children, the most common cause of the aortic stenosis will be bicuspid aortic valve. Right, that will be bicuspid aortic valve in case of the children. Then what are the other causes for the aortic stenosis? The other causes for aortic stenosis will be the rheumatic fever, right? And you also need to know what are the other important risk factors for the development of the aortic stenosis. That includes smoking, hypertension, and as well as the dyslipidemia. So these are the other risk factors which can contribute to the development of the aortic stenosis. Whereas you take the aortic regurgitation. Aortic regurgitation, again, we have two forms, acute AR and chronic AR. And this infective endocarditis and as well as the aortic dissection, right? Infective endocarditis and as well as the aortic dissection. These two can make the individual to develop the acute AR, infective endocarditis and aortic dissection. Whereas the other etiologies like rheumatic fever, hypertension, bicuspid aortic valve, ankylosing spondylitis, Ehlers-Danlos syndrome, osteogenesis imperfecta, and syphilis. These are the one which will cause the chronic AR, right? Whereas acute AR is observed in cases of the aortic dissection and is observed in cases of the infective endocarditis. Okay, so these are all the etiology. And even in case of AR also, what is the difference between acute AR and chronic AR? In acute AR, the patient will directly present with sudden onset dyspnea, that is due to severe pulmonary edema. Whereas in chronic AR, the patient will present with palpitations first and followed by that, the individual will go on to the development of the dyspnea. So this is about the etiologies that are causing your MRMS and as well as the AR and as well as AS. Now, coming to the clinical features. So in case of the mitral stenosis, please remember the early manifestation will be in the form of dyspnea and then followed by that the palpitations. And these palpitations are mainly because of the atrial fibrillation, right? The palpitations are mainly because of the atrial fibrillation. And these palpitations are mainly because of left atrial enlargement. So left atrial enlargement or left atrial hypertrophy makes the left atrium arrhythmogenic, and thereby the individual will develop the atrial fibrillation, and that makes the individual to develop the palpitations. Okay, and this dyspnea is mainly because of increase in left atrial pressure, pulmonary venous pulmonary capillary wedge pressure, and resulting in the pulmonary edema. So dyspnea is mainly because of the pulmonary edema in MS. But in MS, you will have the dyspnea first, followed by that the palpitations later whenever there is development of left atrial enlargement of left or left atrial hypertrophy. Whereas you take in MR and as well as the AR, they will be having eccentric left ventricular hypertrophy. And this eccentric left ventricular hypertrophy is arrhythmogenic, and thereby the individual will develop palpitations. So palpitations are present in MR and as well as the AR. Then the other important features that you will have in case of the MR will be, there will be development of the dyspnea after the palpitations. So this sequence you observe in chronic MR. In chronic MR, you will have the palpitations first and followed by the dyspnea. Whereas in case of the acute MR, in acute MR, the individual will have a sudden onset dyspnea. In acute MR, the individual will have a sudden onset dyspnea. That is what you will observe in case of the MR. Whereas you take in case of the AS, if at all, if the individual with aortic stenosis is symptomatic, the individual is said to be having a poor prognosis. And in all the cases of symptomatic aortic stenosis, the treatment will be the aortic valve replacement, right? That should be done definitely. If the individual is asymptomatic, then we give the drugs which will reduce the afterload. But if the individual is symptomatic, definitely the patient will be requiring aortic valve replacement in case of the aortic stenosis. Whereas you take in case of the AR. In case of AR, in case of chronic AR, the presentation will be in the form of palpitations, and followed by that there will be angina. This angina, it will be mainly the nocturnal angina, and they will also develop dyspnea. Whereas you take in cases of the acute AR. In cases of acute AR, the individual will develop sudden onset dyspnea. And what are the causes for the acute AR? That will be the aortic valve perforation, and that could be because of the infective endocarditis or the aortic dissection. So these are the clinical features that you will have in cases of the valvular heart diseases, right? Then coming to the examination findings. On examination in patients with the mitral stenosis, they will have tapping type of the apical impulse. So if you take this LV apex, it will be there in the left fifth intercostal space in the midclavicular line, and left fifth intercostal space in the midclavicular line, it is not shifted to down and out because the LV is not much affected in patients with mitral stenosis. That is the reason why it will be there in the left fifth intercostal space in the midclavicular line, and it will be a tapping type of the apical impulse, right? What is another important palpatory finding is the parasternal heave. And this parasternal heave, it is mainly because of the right ventricular hypertrophy, right? And this right ventricular hypertrophy is secondary to what? Due to development of the pulmonary hypertension, and that is because of increase in the left atrial pressure, pulmonary venous, pulmonary capillary, and pulmonary arterial pressure. So this will be the palpatory findings in patients with mitral stenosis. Whereas in mitral regurgitation, the LV will have the eccentric left ventricular hypertrophy. So this LV, whenever it is having the eccentric left ventricular hypertrophy, you will have what is called the hyperdynamic type of the apical impulse. So the hyperdynamic type of apical impulse will be there in case of the MR and AR, where the apical impulse is shifted down and as well as out. And the hyperdynamic type of apical impulse mean where the apical impulse is felt, right? The apical impulse is felt in more than one intercostal space, right? The apical impulse is being felt in more than one intercostal space. That is what you will have even in case of AR as well. It is shifted down and out, and that is due to eccentric left ventricular hypertrophy. Whereas in AS, you will have heaving type of apical impulse, where the apical impulse is confined to one intercostal space, but it will be sustained upward lift. That is what you will have, the heaving type of the apical impulse. And this heaving type of apical impulse, what you have to understand is, it is mainly due to concentric left ventricular hypertrophy. Right, it is mainly due to concentric left ventricular hypertrophy. All right, and you take the characteristic pulse in patients with the aortic stenosis, you will have the pulsus parvus et tardus, where there will be a slow rising pulse with late peaking. That is what is your pulsus parvus et tardus. Whereas you take in case of AR, you will have the characteristic pulse that is called the water hammer pulse. And the other important pulse that can be there in case of AR is pulsus bispherians also can be there in isolated severe AR, right? Or in AS with AR together, there can be even pulsus bispherians as well. And if you take the blood pressure in AR, you will have the wide pulse pressure. So systolic blood pressure will be very high and diastolic blood pressure will be low. So that is what you will observe in case of the AR, right? Now, coming to the auscultation finding. So in case of auscultation, you take MS. In case of the mitral stenosis, you will have loud S1, but this loud S1 is present in case of rheumatic heart disease causing mitral stenosis. Whereas if the mitral valve calcification is causing the MS, then you will have soft S1, right? Whereas MS, if it is associated with atrial fibrillation, then you will have the variable S1, right? Then P2 will be loud, and that is due to pulmonary hypertension, and the characteristic murmur in patients with mitral stenosis will be the mid-diastolic murmur, which is a low-pitched murmur which is heard at the apex of the heart. Okay, so where is this heard? This is heard at the apex of the heart. And in early part of the diastole, you will have the opening snap, and that opening snap is due to a forcible opening of the mitral valve, and it's a high-pitched sound, right? It's a high-pitched sound. Next is the presystolic accentuation. So the presystolic accentuation is heard in the later part of the diastole, right? It is heard in the later part of the diastole, and that is due to a forcible left atrial contraction, right? So that is due to a forcible left atrial contraction against the stenosed mitral valve. So this presystolic accentuation, it is loud. So this is about the auscultation that you will have in patients with the mitral stenosis. And in mitral stenosis, there are certain components which will tell you about the severity of the MS. That is A to OS split or the A to OS gap. If it is A to OS gap is narrow, then it is said to be severe MS. If the A to OS gap is wide, then it is said to be the mild MS, right? And another important is the mid-diastolic murmur. So this mid-diastolic murmur in case of the mitral stenosis, it's a low-pitched murmur which is heard at the apex. And in the later part of the diastole, you will have pre-systolic accentuation. And even the duration of the mid-diastolic murmur also will decide the severity of the MS, right? So if the duration of the MS, if it is long, then it is severe MS, right? And if the duration of mid-diastolic murmur, if it is short, then it is said to be mild MS, right? Then it is said to be the mild MS. Okay, so that is what is your how to assess the severity in case of MS on auscultation. Then what will be the auscultatory finding in case of the MR? So in case of the MR, the S1 will be soft. Why is this particular S1 being soft? That is due to incomplete closure of the mitral valve. That's the reason why the first heart sound will be soft. And the P2 will be loud, and that is due to development of the pulmonary hypertension. And these patients with MR, they can go into a state of left ventricular failure, and that is when you will have the third heart sound. Then another important is the pansystolic murmur. So this pansystolic murmur in case of the MR, it is the high pitched murmur. It is heard at the apex, and that will be radiating to the axilla. And when these patients with MR, when they go into the development of left ventricular failure, you will have an additional sound, that is the S3. So in case of the acute MR, we will have what is called Caricum's murmur. And the acute MR, it is secondary to the acute rheumatic fever. So in acute rheumatic fever, you will have the development of a functional murmur, and that functional murmur is the Caricum's murmur, right? Followed by that, you take in patients with the aortic stenosis. The auscultatory finding and examination findings that you will have is, okay, number one, the systolic blood pressure will be reduced, and A2 will be soft because it is a calcific aortic valve. And the characteristic murmur is the ejection systolic murmur, which is heard in the aortic area, and that will be radiating to the carotid. And the additional sound that you will have in case of the AS will be the fourth heart sound is being heard. And these patients, you will have what is called Gallaverdin phenomena. So Gallaverdin phenomena is that the murmur of the AS will be radiating to the apex. That is what is called as the Gallaverdin phenomena, right? So that is what is your AS. Then followed by that, in AR, you will have wide pulse pressure. That is what we have discussed. And in AR, the heart sounds, you will have a single S2, and that is P2, because the aortic regurgitation, the aortic valve is not closing, and that is the reason why there is regurgitation which is happening, and you will have a single S2 or a single second heart sound, and that is P2. And the murmur that you will have is the early diastolic murmur, and this early diastolic murmur, it is a high pitched murmur in case of the AR. And you will have what is called cholecystral murmur, where the AR murmur will be radiating to the axilla, is what is called cholecystral murmur. And you will have a functional murmur, that is Austin Flint murmur, and it is a functional mid-diastolic murmur. And in case of AR, and that too in patients with severe AR, there can also be a functional mid-systolic murmur as well, right? There will be functional mid-systolic murmur as well. So this is what is the auscultation that you will have in patients with the valvular heart diseases, right? That is MS, MR, AS, and as well as AR. Then how do you work up for these patients? In all the patients, the workup is by the 2D echo. All the valvular heart diseases, the first line investigation is by 2D echo, right? And next to the 2D echo, like we can do the ECG. Okay, first of all, let me tell you the 2D echo in case of the mitral stenosis. So in mitral stenosis, apart from estimating the valve area, you will be also able to make out the gradient across the valve, and as well as you will also be able to make out the gradient across the valve, and as well as the pulmonary artery pressure in the patients with mitral stenosis. So first is the valve area. So 1.5 to 2 will be progressive mitral stenosis, 1 to 1.5 will be severe mitral stenosis, and less than 1 centimeter square will be very severe mitral stenosis. Then coming to the gradient. So if you take the gradient in patients with progressive mitral stenosis, between the left atrium and left ventricle, the gradient is less than 5 millimeters of mercury, whereas in severe, it is around 5 to 10 millimeters of mercury, and the gradient between the left atrium and left ventricle in case of very severe will be more than 10 millimeters of mercury. And pulmonary artery pressure is raised in patients with mitral stenosis. So in patients with progressive mitral stenosis, the pulmonary artery pressure will be less than 30 millimeters of mercury, whereas in case of severe mitral stenosis, it is 30 to 50, and in very severe mitral stenosis, you will have more than 50 millimeters of mercury. Okay, so this will be the 2D echo finding in patients with the mitral stenosis, right? Then coming to the ECG. So if you take the ECG in patients with mitral stenosis, you will have what is called the P mitral, where there is left atrial enlargement, and the P wave, it is of M shape in lead 2. And coming to the chest X-ray, in patients with the mitral stenosis, there will be straight left heart border, and that straight left heart border is mainly due to left atrial enlargement, right? And you will have double density sign, and double density sign is also due to left atrial enlargement, and there will be widening of the carinal angle, and that is again due to left atrial enlargement, right? And there will be prominent right descending pulmonary, or you will have prominent pulmonary arteries, that is due to pulmonary hypertension. So this will be the investigations that you will have in patients with MS, right? But the first line investigation is the 2D echo. Then coming to the MR. So in MR, you will notice that there is a regurgitation that will be happening from LV to LA during the systole. And in MR, you will be able to make out two things. One is you should be able to assess the valve, and next is the valve hemodynamics. So you should be able to make out what is the problem in the valve, and you should also be able to make out the valve hemodynamics as well. That is what you will be able to make out in the MR2D echo. Whereas you take in case of the AS, in AS, you will notice that there is left ventricular hypertrophy on the ECG, and that too a concentric left ventricular hypertrophy. And what is the criteria for the concentric left ventricular hypertrophy is SV1 plus RV6. If it is more than 35 mm, that is suggestive of the concentric left ventricular hypertrophy, and the chest X-ray will show you that there is presence of pulmonary congestion. And in case of AS, you will be able to decide the CVRT as mild, moderate, severe. So in case of mild AS, the valve area is 1.5 to 2 centimeters square. Whereas in moderate, it is 1 to 1.5, whereas in severe, it is less than 1 centimeter square. Whereas the next important thing that you will be able to make out is the gradient. Normal gradient between the LV and as well as the iota is less than 5 millimeters of mercury, but in AS, the gradient, minimum gradient should be around 10 millimeters of mercury. In case of mild AS, the gradient should be less than 25 millimeters of mercury, whereas in moderate AS, the gradient should be around 25 to 40. Whereas in severe AS, the gradient will be more than 40 millimeters of mercury. Then coming to the aortic jet velocity. So if you take this aortic jet velocity, in case of mild, it is around 3 meters per second. Whereas in moderate, it is around 3 to 4 meters per second. Whereas in severe, the gradient or the velocity across the aortic valve, that is aortic jet velocity, it will be more than 4 meters per second. That is what you will observe in case of severe. So this is what you will notice in case of AS. Whereas you take in case of the AR. In case of the AR, the ECG will show you that there is left ventricular hypertrophy, and the type of left ventricular hypertrophy that you will have is eccentric left ventricular hypertrophy, where you have the presence of the deep Q waves, right? And the chest X-ray will show you that there is cardiomegaly, and because of left ventricular dilatation, you will notice that the NT-proBNP is increased. And again, the first line investigation is always 2D echo, and the 2D echo will demonstrate the regurgitation. Then coming to the treatment. So in case of the MS, if it is mild or moderate MS, or if it is like progressive or severe MS, we just give beta blockers and as well as diuretics. But if it is very severe MS, where the individual is severely symptomatic, that is the reason why you need to plan for surgical treatment. And that surgical treatment, you have two options, that is percutaneous balloon mitral valvotomy and as well as the mitral valve replacement. Now, when is actually what is being preferred? The PBMV, that is percutaneous balloon mitral valvotomy, is being preferred. But when is that you will do mitral valve replacement? Mitral valve replacement is done whenever there is contraindications to PBMV. And what is that contraindication to PBMV? Contraindication to PBMV will be presence of left atrial thrombus and as well as the presence of the calcified mitral stenosis and moderate to severe MR. Moderate to severe MR. So these are the contraindications for PBMV, and these are the scenarios where you need to do mitral valve replacement. right? These are the scenarios where we do mitral valve replacement. Okay, then coming to the MR. In MR also, the drugs that we give is diuretics, beta blockers, ACE inhibitors or ARBs. When is that you need to do mitral valve replacement? Mitral valve replacement has to be done if the ejection fraction is less than 60% and if left ventricular end systolic diameter is more than 45 mm. That is the point when you need to plan for the mitral valve replacement, right? Then coming to the AS. In all the patients with symptomatic AS, you need to do surgical treatment. And the surgical treatment will be in the form of the transcatheter aortic valve replacement or the surgical aortic valve replacement has to be done. If the individual is asymptomatic, usually we don't do the valve replacement. But what are the indications where in spite of the individual being asymptomatic will be requiring the aortic valve replacement? That is, a patient with aortic stenosis undergoing CABG due to coronary artery disease. Aortic valve has to be replaced if there is underlying aortic stenosis. And the patient with aortic stenosis with LV ejection fraction less than 50%, gradient more than 55 millimeters of mercury between the left ventricle and aorta, and failure of the systolic blood pressure to raise more than 20 millimeters of mercury during the treadmill test, and there is severe valvular calcification. That is the point when you need to do surgical treatment, right? Coming to AR. So in case of AR, the medical management will be in the form of diuretics, ACE inhibitors or ARBs. But please remember, beta blockers should be avoided, right? Beta blockers should be avoided in patients with the AR, right? And coming to the surgical treatment in AR. If left ventricular end diastolic diameter, if it is more than 65 mm, or if the left ventricular end systolic diameter is more than 50 mm, that is when you need to plan for the surgical treatment in case of the aortic regurgitation. So this is the summary of treatment of all the valvular heart diseases, right? So this completes the discussion of the summary of all the valvular heart diseases. So coming to the next question. We have a 42-year-old female presents to the clinic due to the occasional palpitations and mild exertional shortness of breath and chest discomfort. Her blood pressure is 120/80 and the heart rate is 82 beats per minute and regular. There is a mid-systolic click which is heard at the apex and followed by late systolic murmur. The murmur increases in intensity with Valsalva maneuver and decreases with squatting. Which of the following additional finding cannot be found in this patient? Fibrillin 1 protein defect, hyperextended joints, sacroiliitis, and as well as the presence of the blue sclera. So what is this? This is mitral valve prolapse with MR, right? Presence of a mid-systolic click at the apex followed by the late systolic murmur, right? Followed by the late systolic murmur. That is suggestive of the mitral valve prolapse with MR, right? And in patients with mitral valve prolapse with MR, most of the time they are asymptomatic. If at all if they are symptomatic, the most common symptom will be palpitation, right? The most common symptom will be palpitations. Followed by that, the patients will be having the chest discomfort, right? Followed by that, the patient will be having chest discomfort, right? Now, what are the etiologies that will be causing the mitral valve prolapse? See, number one, Marfan syndrome. Actually, fibrillin 1 protein defect is present in Marfan's. It is observed in Marfan's. Then, hyperextended joints are also present in Marfan's. And presence of blue sclera is present in osteogenesis imperfecta. Even this can cause the mitral valve prolapse syndrome. Whereas sacroiliitis is present in case of the ankylosing spondylitis. And ankylosing spondylitis, it can cause AR but not MVP with MR. What are the other causes for the mitral valve prolapse? That includes the rheumatic fever, subacute bacterial endocarditis, dilated cardiomyopathy, and this MVP with MR is associated with ostium secundum type of the ASD, right? Associated with the ostium secundum type of the ASD. If the MR is severe, where the individual is going into a state of the acute left ventricular failure, these patients will be requiring the surgical correction. Okay, so the answer here is sacroiliitis is not associated with the development of MVP with MR, right? Next. Okay, so one of the last question. We have a 45-year-old male presents to the clinic with fatigue, exertional dyspnea and swelling in his legs for the past few months. There is bilateral pitting edema in his lower limbs and elevated jugular venous pressure. Auscultation revealed soft, low-pitched rumbling sound following S2. Apart from the above condition, in which other condition this auscultatory finding can be heard? AS, hypertrophic cardiomyopathy, atrial fibrillation, and then chronic MR. See, what is the finding here? The individual is having fatigue and edema of the lower limbs. So that means the patient is in a state of the congestive heart failure, right? Done. Next, that means both right ventricular and left ventricular failure features are there. Auscultation is revealing a soft, low-pitched rumbling sound following S2. What is that? That is suggestive of S3, right? That is suggestive of S3, right? Now, the presence of S3 is the point suggestive of your congestive heart failure. And what are the other conditions where you will have S3 in the options which has been given to you? It is present in case of the chronic MR. So in chronic MR, you will have the presence of the S3, right? Whereas in aortic stenosis, you will have S4. Whereas in hypertrophic obstructive cardiomyopathy, you will have S4. Whereas in atrial fibrillation, you will have the presence of the variable S1. Whereas in chronic MR, what is that you will have is, there will be development of congestive heart failure or left ventricular failure resulting in the development of the S3, right? So the answer here is the chronic MR, right? So these are some of the very important questions in the cardiology. Thank you very much.